Good afternoon, everyone. Today we're joining myself, Karen Sariego, one of the Improvement Facilitators, and we're going to cover interesting topic today in PACOP in Practice monthly virtual webinar series. So the topic for this month is about navigating rapid decline in residents with cancer. Before anything else, though, we do an acknowledgement. Join me as we pause and say that we acknowledge that the country of the Aboriginal peoples is an interconnected set of ancient and sophisticated relationships. University of Wollongong spreads across many interrelated Aboriginal countries that are bound by this sacred landscape and intimate relationship with that landscape since creation, from Sydney to Southern Highlands, to the South Coast, from freshwater to bitter water to salt, from city to urban to rural. I am coming to you today from the land of the Wadawarong people of the Kulin Nations in Geelong. The university acknowledges the devastating impact of colonization and our campus's footprint and commit ourselves to truth-telling, healing, and education. So what we're hoping to cover today is we're going to touch on surface level overview of PACOP, and we're going to learn a little bit more about the story of Roy, which is our case review for today. Roy has multiple comorbidities, but we're going to navigate his way through admission in terms of using the PACOP tools and navigating that change and identifying deterioration. Now, as for the PACOP framework, we're hoping to apply the framework throughout the admission up until towards discharge. There's two main lanes in the framework. The profile collection is the first lane, and the second lane is the outcomes collection. For the profile collection, it's asking a question for whether or not your resident has an active palliative care need. We answer that question by way of using two clinical tools. One's the clinical assessment tool, which is 3 parts, and then the other one is the deteriorating resident tool. For the clinical assessment tool, we're going to use that on admission and then regularly every 3 months. However, as things change and as required, we are able to use the deteriorating resident tool, which is our go-to tool. And for both tools, they're asking, does this resident have a palliative care need? If it's a no, then we continue the regular checks every 3 months or as needed. But if it's a yes, then we go to the second lane. The second lane is called the outcomes collection or the orange lane. So for the outcomes collection, because we've identified an active palliative care need, then we check on the resident with their daily SAS tool regularly, and that means daily. And apart from that, we also do the full clinical assessment either daily or weekly. The questions we're trying to ask is a care plan effective? Are we meeting the residents' needs? And how often do we need to check on them? So by way of simplifying it, we look at this flow chart. Again, the first lane is the profile. Oh, sorry, I jumped onto the next. First is the profile clinical assessment and then the DRT. They're both asking the same question. Does the resident have an active palliative care need? If it's a yes, then when you look at the bottom, the resident would benefit from palliative care, and then we move them on to the outcomes. Now, let's go and talk a little bit about our topic for today, which is about cancer and navigating the rapid decline about residents with cancer. So what do we know about cancer in our aging population? When you look at key statistics that provided by Australian Institute of Health and Welfare, or AIHW, approximately 21% to 27% of residents in our community have a cancer diagnosis, lung and prostate being the most common, and it could be active. It could also be inactive, but it's quite a big number, isn't it? So it kind of counts to 1 in 5 residents if you look at that. And having that, cancer is also the leading cause of palliative hospitalizations among older Australians, often resulting in high readmission rates, which is quite a surprising thing and could be because of the complexities that comes along with cancer. Over 90% of people dying in an aged care facility could potentially benefit from palliative care approach as early as possible. And the progression of cancer in older adults can resemble a bruised apple. That's why I've got it there. Mainly because with a bruised apple, externally it can appear intact. However, internally it can be very compromised. So sometimes it can trick us, where deterioration may not be immediately that visible, but can advance quite rapidly. So now let's look at Roy. Meet Roy. So this is Roy. Roy lives at home with his wife Anna, who is highly supportive. He's got 3 children. You're more than welcome to take notes as you go along. He's got 3 children who are very supportive, yet they're actually quite distant. They live interstate. He has formally appointed his wife Anna as his medical treatment decision maker. The couple identify themselves as Anglican, though they're not strictly practicing. Roy describes himself as spiritual and expresses a strong connection to the land, shaped by his 30-year career as a truck driver. So he's been driving for a while, all his life, and during which he spent extensive time traveling. So the main issue is that Anna hasn't slept through the last 4 months. She helps him to the toilet multiple times, worried he might fall. Roy can still go to the toilet with minimal assistance, though. However, she is very fearful of him falling, as this has happened twice over the last month and a few times over the last 3 months. Their children call often, but distance means Anna carries the burden alone, and Roy doesn't talk about fear. He is very pragmatic. A little bit more about Roy. Roy places a high value on his family and has taken pride in financially supporting them throughout his life. He's a strong provider and he's strongly maintaining his values both physically and cognitively. He values his independence. Roy thinks that his quality of life includes simple joy of having a beer or two and engaging in meaningful conversations, for which people find very important as well. And for him to be able to complete his needs and day-to-day needs independently and manage it without help is something very important. While Roy acknowledges that increasing support may be required as his illness progresses, he finds that the prospect of being completely dependent on others for his basic care over a prolonged period of time is unacceptable. So that's what Roy highly values. When we look at his medical background, it's quite a big list. And I'm sure when residents come into facilities, you'll probably see residents who've got more diagnosis and comorbidities than Roy. For Roy, he's got hypertension, cardiac failure, reflux, urinary frequency. He's had prostate cancer initially 2020, osteoporosis, type 2 diabetes. He's got metastatic prostate cancer, which has progressed in 2024 and now has metastasized to his bones on his lumbar area and bladder involvement. For his function, though, Roy is fairly independent, although when he's at home, he thinks he's independent, but his wife has been assisting him with his mobility, assisting him with his toileting, assisting him with the transfers, and he thinks he's fairly independent with his eating. However, his wife does all the cooking for him. Now, Roy spent 30 years of his life driving through the mountain roads, and he describes them as really peaceful and grounding. But now his traveling and journey has changed. He arrives in our aged care facility called PACOP, both for himself and for Anna, who has been carrying the weight of his care. He is, however, very accepting of this. Because he does not want to burden Anna. So he does want to try a little bit of respite initially. It was a mutual decision for him and his family. So then Anna can rest. Now, what do we do when we are participating with PACOP and when we have a resident coming into our facility? We then do our initial assessments, don't we? And also, we do the profile collection. Now, let's assume I am the nurse for Roy, and I have this conversation with Roy after I've been doing his initial assessments. And I say, Roy, can you please tell me what you're distressed about by completing the SAS or symptom assessment scale? And Roy then started saying, are you worried about any form of discomfort? And he'll say, I have a lower back pain, but it settles with paracetamol. And then I ask, have you been worried about feeling tired? Roy said, yes, as I am highly independent and I have been relying on my wife more, and I do want to do things for myself, even if it means I need to use an aid. Well, Roy, have you been bothered about your sleep? Mildly, because I'm always going to the toilet, but I do manage to go back to sleep quite easily. The most distressing thing, though, is I don't think I can fully empty my bladder. I just go to the toilet day in, day out. I go to the toilet every time. I know it's part of being older. However, I do hope I can do more about it. And then I ask, how about your bowels? I can get constipated, but I just take prune juice and that's fine. So when you base it on that conversation, I then look at the SAS. Basing on Roy, what's most distressing for him is he's got mild pain. He does have fatigue, which is quite moderate because he's always up and about. Sleeping doesn't bother him so much. He can fall back to sleep quite easily, but he's mostly distressed about going to the toilet frequently, which is moderate for him. Now, as a clinician, I do my assessments and I think, yep, pain could be mild. Other symptoms moderate because of the fatigue and the toilet frequency. Family care, Anna is feeling quite sad. However, they both came into this agreement for then. So then it's respite, so she could still take him back. And looking at the AKPS, Roy, although he seems to feel that he's very, very independent, we know that we need constant assistance and supervision, even when he's going to the toilet because he's high falls risk. So I, as a nurse, would put him down as 50, wherein he requires considerable assistance and frequent medical care. Now then, we look at his RUG ADL. He needs 1 assist for his bed mobility, 1 assist for his toileting, 1 assist for transfer and eating. We prepare the cooking for him and cut it up for him so then it's ready to go. So the total score for his RUG ADL is 11 when I did his initial assessment. Now, when I look at Roy, I kind of think he looks quite okay. So let's just assume that I, for myself, don't have any background knowledge about Roy. He comes in and he looks fairly well. So I do assign him as a moderately frail 6, wherein with this frailty score of 6, people need help with all outside activities and with keeping inside the house. But inside, they have problems with stairs and need help with bathing and might need minimal assistance, queuing, standby, and dressing, which sounds for me quite like Roy. And cognitively, he is intact. So with his communication, he does receive the feedback quite well and communicate it quite clearly, as well as for his family. And since this is the first time assessing them, not applicable for how often the contact happens. Now, with all this information, I do have a question for everyone. Basing on that assessment, when you look at the tools, do you think Roy has an active palliative care need now? Is it a yes or is it a no? So feel free to use the reaction button at the bottom of the screen, or feel free to type it up for yourselves. Just say yes or say no. What do you think? So I'll slowly go with each question one by one. Yes, Anita says yes. For now, we don't really have an ANA class 1. He's not an admit for palliative care. Resident not admitted from palliative care unit. There's no palliative care plan that's in place. He's just come home really, and he's just been here for respite. Resident has documented palliative care needs. Not really. Based on my clinical judgment, I don't think so just yet. When I look at the tools, we do have 1 or more moderate symptom distress, and that was fatigue and also urinary frequency. So I'll say yes to that. His AKPS for now is 50, so it's not 40 or less. And the Rockwood Clinical Frailty Scale for now is 6. So at this point, we would say, just basing on the available tools that we have, Roy does not need an active palliative care. So I'll keep him in profile. However, we know things could change quite quickly, isn't it? So only just 1 week in the aged care facility, Roy becomes acutely uncomfortable. He has been unable to pass urine from last night until midday today, and he becomes really restless and in pain. He requested transfer to the hospital because of those reasons, because he's having bladder retention. In the hospital, they did all the investigations, and then the imaging confirmed that there's progression of his prostate cancer with semi-urinary outlet obstruction. It was then decided we'll insert a catheter to release the urinary retention. And they also did some blood tests, and it showed that the PSA was rising despite the androgen deprivation therapy. So he was an ADT, but despite that, it was still rising. It was then reviewed by the oncologist team, and they were quite concerned about this scenario. And then he was referred to the specialist palliative care team because of his increasing symptom issues, who the palliative care team then has identified that he's got pain. So they looked at pain management for him and initiated breakthrough pain and a background opioid analgesia for him. They also initiated a catheter care plan, infection prevention. So it took a little while. He actually stayed in the hospital for 3 weeks. And then they revisited his goals of care again. And this time, given his increasing frailty, weakness, and weight loss, the progression of his cancer, Roy decided not to accept any treatment such as TERP or to continue his ADT. Roy stated, I just want to be kept comfortable, but I really can't go home as I don't really want to burden Anna. So he said to Anna, what's our options at the moment? Well, Anna said, how about we try and go back to the aged care home? And so they decided to go back to the aged care home. Now, on return to the aged care facility, this is February 3, 2026. It's probably closer to a month from his first admission as respite, and now he's come back. Now, just basing on all those information, do you think he now has an active palliative care need? What do you think? Is it a yes or is it a no? Feel free to type in the chat box. Just basing it on the information that we have. Yeah, we've got a few people. Yeah, we've got a few saying yes, we agree. Let's have a look. So basing on all those information, we think about his symptom issues. Firstly, his pain. He's got back pain, and when he arrived, he's been receiving 3 to 4 breakthroughs in a day. It is effective, but his requirements have increased. He feels really tired and is now getting more reliant. He actually now stays in bed all the time and only gets out of bed to the toilet. He now prefers to have his meals in bed like he did in the hospital. And his urinary frequency, which was a big problem, has now resolved because he's got the catheter. And just thinking about that, he still does have symptom issues, doesn't he? So let's have a look. We assume we've completed the DRT, and on to the last part of the DRT, we have this question, yes or no, identifying the need for palliative care. And remember, we only need one tick. So let's go through this one by one. So based on your clinical judgment and the current assessment and all information available to you, just thinking about the changes that's happened in a month's time, do you think he'll benefit from palliative care? You could say yes, or you could say no. I think I'll say yes for this. And then the next question would say the resident or family is requesting palliative care. Doesn't necessarily say in this situation, so we'll say no for now. But based on clinical judgment, the current assessment, and all information available to you, do you believe the resident has prognosis of less than 3 months? That could be quite difficult to answer, isn't it? So I'll leave it as blank for now. However, if you look at the symptom issues and the tools, we said with SAS, it's moderate for his fatigue as well as his pain, because he does have pain relief, but he's requiring more and more, and therefore the care plan would need some review. His AKPS is 30 now. He's actually spending all time in bed except for when he's toileting. And this time around, the Rockwood Clinical Frailty Scale, is it an 8 or a 9? I would say it would be a 9 now. So just looking at this scenario, you only need to have one tick, but we've ticked 4 areas. And therefore, at this stage, we'll say, well, Roy requires active palliative care, so then we'll move him to the outcomes. But before that, let's just pause and stop and look at the pointers of comparison for the Rockwood Clinical Frailty Scale and the AKPS. Just rethinking when he first got admitted on January 5th, 2026. At that point, for his clinical frailty scale, I, as a nurse, which probably was my bad of not knowing Roy very well, I decided to put him down as moderately frail because he looked well to me and his cancer really didn't stand out initially. He had lots of morbidities. He has frailty because he's been falling as well, but didn't really speak volume so much just yet. However, on his return from the hospital on February 3rd, which is close to 4 weeks from the first admission, I would say then that Roy would be a 9. And why is that? When we look closely into this definition, Rockwood Clinical Frailty Scale of 9 would mean that he's approaching the end of life. This category applies to people with life expectancy of less than 6 months and are not otherwise evidently frail. He does look a lot frailer, but he could still present quite well compared to any other residents too. However, we need to understand the reason of care. It was discussed in the hospital that his disease has progressed, specifically his prostate cancer. Now let's look at the AKPS as well. So I love AKPS or the performance scale because it's very simple and easy to use when you look at the definitions of each. When he first arrived in the aged care facility, in the PACOP aged care facility, on January 5th, he was a 50. However, on return from the hospital, he's actually gone down to a 30. Now that's a big drop, isn't it? So just given this rate of change in just 1 month, where the AKPS has fallen from 50 to 30, what does that tell us? It can guide us into the possible projection and how things could change. And then let's remember about the trajectory of cancer too, where it could possibly actually go and drop down quite quickly to 20 and 10 in the next few weeks, given the progression. So it's important to understand the change, the rate of change, and how quickly things are changing, because it allows us to then understand the possible projection. So coming to this point, because we're moving Roy to the outcomes, what are the possible things we need to do? Like as nurses, when you're assessing Roy, having all the information that you have, what do you think we should do? And feel free to type it in the chat box. If you're the nurse for Roy, what do you need to do? Now, do we need to organize a family meeting? Potentially. Although he's had discussions in the hospital, what do we know? Sometimes what we see is that families would probably need further discussions about what they understand, because hospital can be quite overwhelming, isn't it? There might be so many things that they have missed, and we could only take in so much. So we need to clarify, what does the family know and what do we see? And we could also use the tools to give them a comparison based on observational cues. We take yes as well to commencing outcomes collection, because there's lots of yeses to saying he does have an active palliative care need. We need to probably develop and revise an end-of-life care plan, and also his care plan, ensuring that we are able to meet his needs, especially for pain, and also discuss about other ways to manage his fatigue. His advanced care plan might have changed a lot, although he did say in the hospital with his goals of care that he wants to stay in the aged care facility. We need to really clarify this goal because things have changed. I could see there's quite a few scribbles in the PowerPoint. That's good. It's kind of it tells us there's so many other directions. And as nurses, we know very well that there's lots of other things we take into consideration. And it takes a village. We need to really check on his psychosocial and spiritual being, and also really look at allied health team and the rest of the team that could assist us with caring for him. Right. I wonder, just to stop and pause, is there anything else apart from those lists, from those information there? Is there anything else you feel that needs to be added? So feel free to write in the chat box as we go along. Now, once we're in the outcomes collection, we then complete a full clinical assessment that determines the phase of care. Now, let's try and relive what his main issues are. His issue would include his back pain, having 3 to 4 breakthroughs in a day. So that is a moderate. He feels tired and he's getting more reliant and now stays in bed most of the time and only gets out of bed to the toilet. He also now prefers to have his meals in the bed. So the only time he gets out of bed is going to the toilet. His pain is moderate, his fatigue is also moderate, and he's actually quite distressed by this because he's a very independent man. Anna, although she is accepting of the change, she is feeling quite sad and distressed. Now, just having to look at those information, the SAS and the PSS, thinking about the family and carer, what do you think is the phase of care for Roy? Now, just as a reminder, what we can do is let's try and work around together and look at the flow chart for us to come to the phase. So I'll first ask the question, is Roy expected to die within days or weeks? He's eating quite well. He does have a mild pain. He's cognitively intact, but things are changing. Let's assume I'll say no to this for now. So I'll jump to no. Then we ask about the care plan. Is the current care plan meeting his needs? Is it yes or a no? Going back to his symptom issues, he does have issues that needs to be met, and his carer is somehow distressed. So we need to address that. So I'll say no for now, but is urgent action required? If he's got pain that's increasing, there's two ways to go around this, and it really can be subjective to how Roy is presenting to your facility. But let's just say I'm very, very proactive, and I say I want to change the care plan and intervene straight away. So what I do is, then I allocate the phase of unstable because I need to change the care plan straight away. I need to escalate the need straight away. So then for now, what does unstable mean for a phase? When the resident is in outcomes and is having an unstable phase, we then look at making sure that we do our SAS every day regularly, and we also do our full clinical assessment daily. So this is just a reminder on how we go about that. But please know that the phases in outcome can be ever so moving and can be fluid. It can jump from stable to deteriorating to unstable. However, terminal trumps all the phases. Once we've identified that Roy would only have a few days to a few weeks to live, we then allocate the terminal phase. How about you, team? What do you think? Did you allocate terminal straight away, or did you say unstable for now? Feel free to type in the chat box. So now we've come across Roy and we've used a lot of the PACOP tools. I just want us to stop and pause and look at the different trajectories in palliative care. It's quite a busy image, isn't it? But it's a very familiar image to all of us. Now, palliative care trajectories describe the patterns of decline towards end of life. And generally, it's categorized into three different areas. When you look at the blue category, the blue line is the rapid decline, which is usually related to cancer trajectory. With cancer, you could see the residents who's really relatively stable. And as I've said about the bruised apple, it could trick us because they look quite well. Like Roy's admission initially for respite, he was relatively stable, but then he had a very steep decline following in the following weeks of his admission. And this trajectory can be very helpful because often it's highly predictable, allowing for early and structured planning. The second part, though, is a little bit tricky. When you look at the orange line, it's the organ failure trajectory. And this is where it's intermittent. And typically, it falls for the chronic illnesses category like COPD or cardiac failure. And this involves a gradual decline and then a sudden drop, interrupted each time by an exacerbation. And every time there's an exacerbation or crisis, it increases the risk of death. And the recovery is always going to be lower than how it was as their baseline, making it actually quite difficult to predict as to when the last drop would be. The last part too is another tricky one, which is the green line, which is a trajectory for frailty and dementia. And it's usually a long-term, slow, progressive reduction in physical and cognitive function often over the last several years. And these residents frequently require high-level long-term care for activities of daily living. So what are the clinical implications for understanding the trajectory? It can be really helpful because for predictability is first thing. Cancer often allows easier planning because we know the trajectory is quite predictable. And therefore, we need to have that early planning and discussions. For care planning, we need to understand the trajectory. It allows us to have advanced care planning in place as early as possible, especially for residents with dementia who might not recognize their condition as a terminal illness. It also helps us with resource allocation and timing. Palliative care is most effective when introduced really early. However, what we see nowadays is that there's sometimes a combined trajectory, isn't it? Which makes it really complex and really difficult to really pinpoint as to which trajectory they go to. The combined trajectory requires treating the resident as having both chronic and terminal condition, which can have acute episodes requiring flexible proactive planning. So hence, it is really important that as soon as they get admitted into the facility, we screen everyone. And that's why with profile collection, we do it on admission and then regularly. That way, no one falls through the cracks, because if they're for admission, whether for respite or permanent care, at least we understand what their baseline is, and then we capture the change quite regularly all throughout. That's the reason why we do this screening quite regularly and every time. And you kind of look at Roy's trajectory, it's happened really, really quickly. And we've only known Roy for only a few weeks, isn't it? So it's good that we managed to screen him and review his advanced care plan and have this communication open all throughout. Now, just pointing towards the end of this discussion, case study learnings, one thing that we could always rely on when you're using the PACOP framework is using the deteriorating resident tool. Deteriorating resident tool is what we call the go-to tool, the green tool, because it's a condensed version of all the assessments, but it's a good tool to grab where we can actually complete an assessment in 5 minutes, and it tells us, does this resident have an active palliative care need? A lot of family members and staff members have told us that they've been using it when discussing alongside family, because it allows them to be able to actually express and objectively show to the family how things have changed, especially for the ones who can be very emotive as to the change. And sometimes it's just nice when family members are not actually able to visit them quite regularly. At least you have a way of comparison on how things are changing. Another important key learning is it's good to know the reason for care. Throughout PACOP, we always ask, what's the reason for care for this resident? What's the reason for their deterioration? It's important because, as we talked about earlier on with understanding their trajectories, it then allows us to plan. And specifically for Roy, his reason for care, especially after the hospitalization, was cancer, the metastatic progression of his cancer, which then we could expect a rapid change. And although it may look like it's probably way early, we kind of feel he probably is still presenting quite well. But then when we looked at the DRT, it did tell us he does have an active palliative care need. And therefore, we started doing some planning and proactive communication with the family. And lastly, we need to utilize available tools and apply clinical reasoning beyond standard approaches. It's meaning making about what the tools are trying to tell us. And it's a bit about being a detective too. Sometimes the tools can just provide us evidence, but then we need to really understand the whole person beyond that evidence. And specifically for Roy as to what's important for him. Now, communities of practice, I just wanted to really let you know that when you're participating with PACOP, communities of practice is available for everyone participating. It's something that's worth discussing about with your team leaders or your organization as a whole, because this is where we learn these cases. This is where we understand Roy beyond the tools. And it's a safe space to discuss case scenarios and look back and looking at what can we do to make things better and what have we done very, very well together. And it's also a good space for learning, for not just for you, but for all of us as well as improvement facilitators. Now, we have so many resources. If you're not participating with PACOP, I would suggest you could visit our website. If you wanted to use any of the resources, whether it's profile, the DRT that I've spoken about, or the outcomes collection, you could actually access it through our website. You just type uow.edu.au, and in the clinical section, you could download so many of these tools. Apart from that, if you wanted the family members to learn more about what PACOP is about or what SAS is about specifically, you could also download different information leaflets, and they come in different languages: English, Greek, Italian, Spanish, and Chinese. So more than welcome to download that. That's free for everyone, and this is how it looks like. And another thing is that you could learn more about us. Even if you're not registered with us, you could actually visit our site and do some e-learning courses where it's self-paced. You could complete it yourself and come back to when you're ready. But usually the course, the introduction specifically, is an hour, and it gives you a good overview of what PACOP is about. And in our YouTube channel, we also have 5 to 6 minute videos of the use of different tools. So you're more than welcome to use that as well. There's quite a few things you could use, and it's available for everyone out there. Now,